is extracorporeal shock wave lithotripsy, which was very popular around 2 decades ago. Now it has fallen out of favor because of some disadvantages like low success rate. In case of very hard stone, the stone clearance rate is very poor, and many times they require additional procedures like ureteroscopy, stenting to clear the remaining stones. Now, commonly done procedure for ureteric stone is ureteroscopy and laser lithotripsy. This is a small video where you can see that stone is in the ureter, and we are breaking with the laser. So we are just dusting the stone with the laser. Once it is clear, we will put a stent which will be removed after 2 or 3 weeks. Now the latest, because of the latest available technology, the RIS, that is retrograde interventional surgery, is very commonly done for kidney stones and upper ureteric stones. Earlier, because of rigid ureteroscope, we could not reach the upper ureter and renal pelvis. Now, because of availability of flexible ureteroscopes, we can reach the kidney very easily and break the stone with the laser, either thulium laser or a whole beam laser. You can see that with the help of laser, we are just dusting the stone, and this is like the end picture where like you can see that like sand kind of thing, we call it as a golden sand, and the small fragments which are left behind, which are also dusted or removed in the basket. So the advantage of this RIRS is there is no need of any like making an incision over the body to remove the stones. So recovery will be very fast. Then we will discharge within 24 hours. And for a large kidney stones like more than 2.5 centimeter stones, we do percutaneous lithotomy. This is a patient will put in prone position, and a fluoroscopic guidance will make a small hole in the kidney, enter the calyx and reach the renal pelvis, break the stones with the laser pneumatic lithotripsy and remove those stones. And the incision will be hardly like half an inch or 1 inch. And you can see that these are the stones, large staggerm stone which is fragmented and removed. This is a quantity of stones. Now coming to the laparoscopic technique for removal of kidney stones. Whenever there is a large ureteric stone like more than 2.5 centimeter, in this case it is around nearly 4 centimeter stone in the ureter, and these stones it is very difficult to manage with ureteroscopy. So instead of doing open surgery, we can do laparoscopic surgery to remove the stones. This is a ureter which is being exposed. And incision is made over the ureter. You can see the urine coming out, which is obstructed. And the stone is removed like completely without making it pieces. And later the stent will be placed inside the ureter. And that ureterotomy incision will be closed with veiwer. The stent will be kept for around 4 weeks, then it will be removed. So again, this is a large kidney stone which is around nearly 4 centimeter. So option for this stone again is a percutaneous lithotomy or open lithotomy. So this patient underwent a laparoscopic lithotomy, and this stone of almost like the size of an egg was removed. So now coming to the other common urological problem is prostate problem. So generally prostate diseases are classified into non-cancerous enlargement, it is BPH, and a cancerous enlargement, which is carcinoma of prostate, and prostatitis, particularly in young patients where they will acute or chronic prostatitis. So generally, whenever there is a prostate enlargement, they present with lower urinary tract symptoms like increased frequency, urgency, reduced stream, nocturia, urinary tract infection, hematuria. And when we suspect there is a prostate problem, we do a clinical examination, like examination of the prostate with rectal examination, distal rectal examination, to assess whether it's a benign enlargement or a cancerous enlargement. Then we do a couple of investigations like urine routine, urine culture, renal function test, serum PSA, which helps in deciding whether the enlargement is a cancerous or non-cancerous. And along with that, imaging, ultrasound with post-ward urine, and uroflowmetry, which shows us the flow rates. So because of availability of very good medicines, now the majority of the patients can be treated with medical management. So this is, you can see, a normal prostate, and this is the enlarged prostate which is causing obstruction to the urine flow. So medical management mainly depends, as all of you know, like alpha blockers, very commonly known drug is Urimax, and along with that dutasteride, which helps in preventing further enlargement of the prostate. And surgical therapy is indicated when patients have refractory nodes. When urinary tract symptoms, they don't respond to medical management, they don't respond to medicines. If they have recurrent urinary tract infection, if they have recurrent hematuria, retention of urine, if there are associated bladder calculi, and if this is prostate enlargement is causing any obstruction to the upper urinary tract, like hydronephrosis leading to rise in creatinine. In these cases, we need to do a surgery. And there are different techniques of doing a prostate surgery. One commonly done is like TURP. In that, a silent TURP, that is called as bipolar TURP, where the side effects of this TURP, like absorption of fluid, is very less. And when there is a very large gland, like more than 50 or 60 grams, we can do laser enucleation of the prostate, either using thulium fiber laser or holmium laser. The advantage of laser enucleation is we can remove almost near complete prostate, except leaving behind a capsule, and the bleeding chances are very less. The need for blood transfusion is also very less, with an excellent outcome. Now, when we suspect a carcinoma of prostate based on the rectal examination or rise in the PSA, so we evaluate further by doing a transrectal biopsy and by doing a PET scan to stage the disease. If it is confined to the prostate, not metastasized to distant areas, then we can cure the disease by doing radical prostatectomy. If it is a metastatic disease, then we have to we can't do surgery. We have to treat them with a hormonal therapy or chemotherapy or radiation, depending on the stage of the disease. So now, other very common problem which we come across in day-to-day practice is urinary tract infection. So whenever a patient comes with urinary tract infections, there are a few things which are very important. One is we have to localize the infection, where it is, whether it's in the kidney, or it's in the bladder, or in the prostate. If it is in the kidney, whether it's a pyelonephritis, emphysematous pyelonephritis, whether it's in a pyelonephrosis, the obstruction, is there any renal abscess, perinephric abscess. And second thing we are interested is knowing the acuteness, whether it is acute UTI or a chronic or a recurrent. So based on these things, we are going to plan the treatment. And what is the severity of the UTI, whether the patient just came with a mild dysuria, lower abdomen pain, fever, or a patient has come with a high-grade fever, chills and dryness, flying pain. If there is any signs of shock like hypotension, tachycardia, then it requires immediate and urgent attention at the tertiary center. And we have to decide whether it's an uncomplicated UTI or a complicated UTI, because the treatment for both the problems is different. So uncomplicated UTI is the one which doesn't have an associated function or a structural abnormalities in the urinary tract. Whereas complicated UTI is the one which has got a functional or a structural abnormalities like a prostate enlargement or a stone obstructing the ureter or a neurogenic bladder. These are the complicated urinary tract infections. So whenever there is a pyelonephritis, patients will have a flank pain, fever, chills, dysuria. So urine culture is a must. Whenever a patient comes with the symptoms of UTI, please do urine culture. Then only start an antibiotic. Empirically, you can start till you get a culture, but without sending urine sample for culture, don't start the antibiotics. And do a complete blood count to know the leukocyte count and renal function test, and imaging either an ultrasound, CT or MR, depending on the severity of the symptom. And some patients might require endoscopic evaluation in the form of cystoscopy also. So I will say a couple of complicated UTI cases. Here you can see a patient present with left loin pain and fever, left kidney there is a really alkaline and there is one stone in the lower ureter. So patient was taken up for suspected infection pyelonephritis, and patient was taken up for cystoscopy and digestiting. Here you can see we are connecting the left ureteric orifice in cystoscopy findings. You can see a frank pus coming from the left kidney. So the patient was diabetic with obstructed calculus in the ureter and with a pyelonephrosis. So with the stenting, patient recovered, and 4 weeks later when the urine culture becomes sterile, we went and removed the ureteric stone. This is a pyelonephritis with obstructed angle papilla is very common in diabetic patients. Here you can see a hydronephrosis on both sides in diabetic patient, and initially they were stented, and once infection was cleared, we did a ureteroscopy, and these are the papilla. This is renal part of the kidney. In diabetic patients, because of endarteritis, this renal papilla gets sloughed off and comes and gets obstructed in the ureter, causing obstructive uropathy and pyelonephritis. The another very dangerous condition is emphysematous pyelonephritis. It's a pyelonephritis common in diabetic patients. So whenever you see a air pocket in the CTR ultrasound, so you have to think of emphysematous pyelonephritis, and patient requires urgent, immediate attention in the form of IV antibiotics, admission, observation, and might require digestion also. You can see very severe emphysematous pyelonephritis where entire kidney has been replaced with gas. So in this patient, the mortality rate is nearly 40% if you don't treat at the right time. So other common problem we come across is urinary incontinence. There are different types of incontinence. One common type of incontinence is urgent incontinence, particularly in the female. We come across this problem. We call it as overactive bladder. It's idiopathic in majority of the patients, particularly in female. And these patients are treated with anticholinergics. So that will help in relieving their symptoms. The other causes for urgent incontinence are like in men, BPH, neurogenic bladder. So as I said, the treatment is anticholinergic, whereas in BPH patients they require alpha blocker also along with anticholinergics. Second type of incontinence is stress incontinence. It's common in female, particularly in above 40 or 50 years because of the weakness in the pelvic floor muscles. Whenever there is a rise in intra-abdominal pressure because of sneezing, coughing, the urine leaks out. If it is very severe, then you have to do a surgery by putting a mid-urethral sling. That will relieve their symptoms. Third common type of incontinence is overflow incontinence. So whenever there is retention of urine, either because of stricture urethra, the urine will overflow and they present as incontinence. So in this case, we have to examine the patient to see whether a retention is there and do a scanning. And if there is an obstruction and if there is retention, we need to catheterize the patient, because treating this patient with medicines will not help. And other common problem is hematuria, blood in the urine. So blood in the urine is quite scary for many patients. So it could be a simple urinary tract infection, or it could be a malignancy in the urinary tract. So all these patients with hematuria requires evaluation to find out what is the cause for hematuria. If it's UTI, kidney stones, and BPH, we can treat with medicines and surgery if required. Whereas this cancers, kidney cancer, ureter cancer, bladder cancer, and prostate cancer requires thorough evaluation and management depending on the location of the cancer. So don't ignore this hematuria. Whenever it needs a complete evaluation. Another cause is papillary necrosis, as I mentioned earlier, and in particularly in children. So it's a glomerulonephritis is also common cause for hematuria. So investigations are like urinalysis, culture, contrast channel, CT scan, or MRI, and sometimes cystoscopy is also required. So apart from these common urological problems at Sparsh Hospital, we give all urology services, like as I mentioned, urological cancers, kidney cancer, bladder cancer, testicular bladder cancer. We regularly do kidney transplant surgery for patients with CKD and digital renal disease, and I do laparoscopic donor kidney harvesting, which helps in fast recovery of the donor. We also do pediatric urology, and we have my colleague Dr. Giriraj, who is an andrologist who takes care of the men's sexual health and male infertility. Like he does penile implant surgeries and varicose surgery, and if any surgery required for male infertility. So thank you very much for your patience hearing.